Headaches, the subject of Audio Digest Psychiatry, Volume 24, Number 12. First, migraine, current approaches to management, by Elliot A. Schulman, Associate Professor of Neurology at Temple University.
Headache is a major problem in the United States. It affects about 20% of the population on an ongoing basis, and within any year, about 95% of the population has some kind of headache. It's the number 2 reason that people see physicians, and there's over $5 billion lost because of lost work days. And we're not addressing young females. The majority of the headaches sufferers who can't interact with their children, family, etc. Patients that we see at the Comprehensive Headache Center are patients who have been to see other physicians, other psychologists. They have had Rolfing, they have had chiropractics, they have had allergy, they have been evaluated for TMJ, they have been evaluated for eye problems. They have also been seen by other neurologists. Some of our biggest referrers are other neurologists. So we're talking about patients who have difficult headache problems who come to us with a certain degree of anxiety. And the degree of anxiety is, number 1, I'm going to see another doctor. I don't know whether he's going to get me better. And number 2, I hope this doctor can get me better because he can't. He's supposed to be an expert in the field. We try to tell our patients at the outset that we are going to address their problems in a systematic way, have them go through our center. We discuss our patients at length over lunch, and then come back and present what we think is a cogent plan for that patient. We also emphasize, however, that this is a treatment. It is not a cure. And you are responsible and must take responsibility for some of the actions that we would like you to do. First thing we do is remove some of the triggers. We start a wellness program. We tell our patients to do things that people should be doing to begin with. Regular exercise, and I'll tell my patients to start by walking around the block once. And the next time you see them, they're walking a mile. And then the next time you see them, they're at a gym. We ask them to do regular stretching exercises, balanced meals, and adequate sleep. We use psychological therapy. Oftentimes these patients are depressed or have other psychological problems, such as abuse as a child. Some of them may be bipolar. And in fact, we also have patients who have multiple personality disorders. On our team are 2 psychologists and 2 psychiatrists who are integral to making these patients better. Physical therapy for patients who have pain around the neck, but our mainstay of therapy is really pharmacology, and that's what I'm going to be talking about today. When the patient comes to our center, the first thing we do is try to establish if there's anything that provokes the patient, provokes the headache. We ask them to write down every headache that they had, when it started, when it ended. We have our patients rate their headaches from a 1 to a 10. A 1 is a very, very mild headache. A 10 is an intolerable headache that sends the patient to bed. What are the triggers? Medication dosage. One of the things that we try to do is clarify how much medication the patient is taking. And there's an entity called analgesic rebound, which can actually make the patient unresponsive to the usual and customary treatments that would help a patient who was in virgin treatment. And then relief. How good was the relief? How long did it last, etc. Now, a lot of our patients get headaches on Monday morning. Some of our headache patients get them on weekends. Some of them only get them on vacations. And that's important to know, because some of these patients, when they do have their headaches, they may suffer their headache after their stress. And we think that's related to the fact that there's a lack of structure, and that is stressful for the patient. We talk obviously about foods. Some of the big things that patients will say bring on their headache are cheeses, aged cheeses, pizza, beer and wine, MSG, Chinese foods, and chocolate. Now, patients will say, you know, what I've done is I've cut out all these foods and I'm still getting my headache. My response to that is, well, we can't definitely say that your headache is caused by these foods. What I tell my patient is, unless you're getting a headache every time you eat chocolate, and that's the only thing that you can link it to, then you don't need to cut chocolate out of your diet. And that's important because we have patients who come to us on boiled rice and chicken that has absolutely no flavor. They're not eating their hoagies, they're not drinking their beer, they're unhappy, and their headaches haven't improved. So what we want to do is try to restore them back to a normal lifestyle. And then the emotional triggers. Obviously, family upset, business success. I had a stockbroker who came to me who was working on this phenomenal merger. He couldn't go into it because it was privileged information, but apparently it was going to be very lucrative for him. And he said, I'm doing phenomenal. I haven't had a headache in, geez, now it's been 3 weeks. The day after the deal closed, he had a terrible headache. So sometimes that sort of unstructure leads to a headache. As I mentioned, patients get headaches around the time of vacation. One of the big things that we see is obviously in females is headaches associated with menses, oversleeping, weather is a big precipitant, changes in atmospheric pressure, missing a meal, and other. And what we try to do is identify what are the triggers that are causing this. When we treat a patient, what we want to do is treat them pharmacologically, physical therapy, and psychotherapy. When we treat a tension-type headache, you need to differentiate between an acute and a chronic tension-type headache. An acute tension-type headache is somebody who gets a headache less than 3 or 4 days a month that responds usually to an over-the-counter analgesic. The patient will describe a tightness. It's usually not associated with nausea or vomiting, and the patient can usually work through it. Patient with chronic tension-type headaches, they get their headaches more than 15 days a month, and many of them will have them every day a month, and that's a different kind of entity. It's also important to consider analgesic rebound. Analgesic rebound is where patients are taking more than 100 analgesics per month, and we're talking about Tylenol, aspirin, or any drug that has Tylenol or aspirin in it. Talking about the combination analgesics, Fioricet and Fiorinol. We're talking about Midrin. We're talking about Exetol. We're talking about Frenulin, as well as ergots, as well as Imitrex and DHE. People think that you can rebound from DHE. And you need to clarify that, because if a patient is a rebounder, by that, and as I explained to my patients, some of the receptors, serotonin receptors, seem to get downregulated because there's so much analgesia around, and your body becomes habituated to the analgesic. And if you don't take your analgesic, you're going to get a headache. And obviously this leads to a vicious cycle where patients are taking more and more and more analgesics to get rid of their headache, and in fact they should be taking less. Consider psychological factors, depression, drug-seeking behavior, and again, pharmacotherapy. Now, when you've got somebody who's got a headache, you want to do the simple things and try to get them back functioning again. We use simple analgesics. You've all done this, I'm assuming that you've had a headache. Combination analgesics, with or without a mild sedating agent, non-steroidals, or narcotics in combination with analgesics. Again, it's important to limit the use of analgesics, because if they're taken on a regular basis, they're going to cause analgesic withdrawal, and that's going to cause a problem for the physician who's got to get them off of it, and a problem for the patient who may experience a much worse headache as they come off the combination. That's abortive treatment. When you're treating somebody symptomatically, what you want to do is give them a medicine on a daily basis which is going to prevent their headaches. What you want to do is start treatment as early as possible, have the patient go into a quiet, dark room, apply ice packs or cold packs, and then use medication. And the medication that you use really depends on how often you're getting the headache, what's used in the past, what the patient responds to, are they rebounding, what is their medical condition, what's their age, do they have a normal EKG, etc. But commonly we start with analgesics, and they can be simple analgesics or combination analgesics. Antiemetics are very effective. Sometimes when I have a patient who comes into the office who is debilitated by their headache and takes aspirin but still has a lot of nausea, a compazine suppository or some Reglan will be enough to get them back functioning. Some patients become very anxious about their headaches. It's a feeling of doom, and that sort of stirs things up and makes their headache worse. So in certain selected patients, we will use small doses of anxiolytics, a small dose of Ativan or Xanax. Nonsteroidals are very widely used. The problem with the nonsteroidals have things that we need to be worried about, including the hepatic and the renal toxicity, in addition to stomach upset and ulcers. We use ergots, we use Kefirgot, we use DHE, and we use a cousin to the ergots, Imitrex. We use steroids, major tranquilizers. We try to keep the patients off narcotics. The patients that we are seeing are people who commonly have at least 8 to 10 major headaches per month, with probably a chronic tension type headache in between. Fioricet is Tylenol, Fiorinol is aspirin. We use butalbital, which is a mild sedating agent, a narcotic, and we may use an antiemetic. Now, when you use Fioricet again, you're using Tylenol, butalbital, and caffeine. Caffeine is a mild vasoconstrictor and may augment the primary analgesic. The anxiety is alleviated by the barbiturates, and by taking a combination analgesic, what you can do is take one medicine which has a lot fewer side effects than if they were to have to take 3 or 4 aspirin or Tylenol by themselves. We've talked about the Fiorinol, we've talked about the Fioricet. I use 1 or 2 tablets every 4 to 6 hours, no more than 6 an attack, no more than 12 a week. So I'm trying to limit my patients to 10 or 12 Fioricet or Fiorinol per week. By the way, if you take 10 Fiorinol and if you take 2-1, 2-1 for a week, you're going to get analgesic rebound by the very fact that you're taking them on a daily basis. So it's not so much the total number, it's the pattern in which you're taking them. I will use Fioricet or Fiorinol with codeine. This I use in my patients who have menstrual migraine. This is a difficult entity to treat. I don't want to get into it, but it may involve hormonal therapy, etc. And for some patients, giving them a prescription for 12 Fiorinol with codeine a month will make them very comfortable if they're having menstrual migraines. We also use Midrin. Midrin is Tylenol. It's isometheptane, which is a mild sedating agent, and dichlorphenazone, which is a mild vasoconstrictor. This is a good agent for people who cannot use ergots, either because they've had untoward effects from it or there's a medical contraindication such as angina or Raynaud's phenomenon, etc. What we do is we give the patient 2 tablets at the onset and then 1 every hour up till a total of 5 or their headache goes away. Again, the key here is avoid analgesic rebound. They can only take it twice a week. We use a whole lot of nonsteroidals. And I think the big point about the nonsteroidals is there's 4 major groups to the nonsteroidals. And because one nonsteroidal doesn't work, you can jump into a different group and you might have success with that. I use a whole lot of Anaprox. I like Anaprox because it's not real upsetting to the stomach. And I'll use 275 up to TID, PRN. If that doesn't work, these are my preferences. I mean, I've also had Voltaren or Clinaril helpful. I usually go to Indocin. Indocin is particularly good with people who have menstrual migraines. And you can use an Indocin SR once or twice a day. Indocin can also be used in anticipation of a menstrual migraine. So if that somebody has a headache on the first day of their period and they're very regular, on day 3, 2, and 1 prior to their period, I will give them Indocin. I've also had some success with Feldine, and I've also had some success with Dolabid. I've been using some Relafin. I've had some success with that, and I've used some Daypro, and I've had success with that. As I said, our major concern is monitoring for nephrotoxicity. Because our patients come in having taken a lot of over-the-counter analgesics, many of them are aspirin intolerant. So we have to go through and decide whether putting them on histamine blocker, an H2 blocker, is going to be adequate. Some of my patients have had bleeding ulcers, and they just got out of the hospital for that. This complicates the matter. There are certain headaches, which I'll talk about, which are Indocin responsive. They do not respond to any of the other nonsteroidals. There's a problem called chronic paroxysmal hemicrania. Chronic paroxysmal hemicrania is like a cluster headache, except it occurs in a female, It's a very, very severe pain with eye watering and nose stuffiness on the same side of the headache, which occurs 15 or 20 times a day. You put the patient on Indocin, they just met you, they've been to many other doctors and doctors have not tried it. They get better within 24 hours. Cough headache. Patients who do a lot of coughing because of COPD or because of another pulmonary problem, patients will respond to Indocin. The caveat is when somebody's got a cough headache, you need to make sure that they don't have something going on in their cervical region, like an Arnold-Chiari malformation or a cervical tumor. Ice pick headaches. This is the kind of headache that people will say, gee, I get this jib or this, it's like an ice pick, it lasts only a second. This is the kind of headache that patients will tell you after their third or fourth visit, after you've made a lot of progress on their migraine. These are called jibs, jabs, and jolts. That's what I refer to them as, and they respond to Indocin. Benign orgasmic cephalgia. This is a very common headache. It's seen about equally in males and females, can occur during the sex act, either prior to or with orgasm, and is a severe headache out of the blue. When you get a call like this, your major concern is making sure that the patient did not have a subarachnoid hemorrhage. So what you want to do is get the patient into the ER, get a CT scan, do an LP, have the patient admitted, make sure that nothing's going on. The treatment for this is taking about 25 or 50 milligrams of Indocin prior to sex, about a half hour prior to sex. This is also useful with exertional cephalgia. Patients who get on their stationary bike for a half hour and then get a headache. Indocin is going to be very helpful. We don't know how Indocin works, but it's peculiar to the nonsteroidals. We think that it reduces cerebrovascular permeability, it lowers CSF pressure, but the actual sites of action have not been clarified. Now, I talked to you about using antiemetics. We use Reglan commonly. We also use Phenergan. We also use Compazine. We've had good success with these. Some patients may take a Fioricet and they may take a Compazine. They may take the Compazine prior. Sometimes the Compazine in and of itself will take the headache away. Again, here I'm worried about tardive dyskinesias. And I tell my patients, look, you're on a very effective drug, but I need to warn you, you can't overuse it. I don't prescribe it more than for 12 Compazine suppositories at a time. They don't get a refill. They cannot take more than 2 Compazine suppositories in a day, twice a week. The big drug that we use abortively is ergotamine and DHE. The ergots come in various forms. It used to come in a nasal spray. It comes as a sublingual. It comes as a suppository. It comes as a pill. I particularly like the suppository. The suppository has the advantage of being able to titrate the dosage. Now, if you send somebody home and you tell them, look, the next time you have your aura that you're getting a headache, take a Caffragate suppository. Well, gee, doc, I felt absolutely great. My headache went away, but I was vomiting for 3 hours. What we want to try to do is eliminate the vomiting, and if they are vomiting, are they vomiting from their migraine? So we have them do a Caffragate trial. When they are not having a headache, we have them take a quarter of a Caffragate. Tolerate it? Fine. Now I want you to go up to a half. Go up to 3/4. That's where I started getting nauseous. They know that they can only take a half of a Caffragate. So if they take their half a Caffragate and they're still vomiting, they're vomiting from their migraine. The absorption is much better and it's much more effective. The side effects that we see, nausea, vomiting, a lot of paresthesias, cramps, and angina. I like to try to check my patients for pulse, and before I put anybody on an ergot, I get an EKG on them, even if it's a healthy 20-year-old. We've had patients who have developed angina on DHE. We've had patients who have developed angina on Caffragate. If we get a call in the middle of the night, you know, I took my Caffragate, now I've got this terrible crushing chest pain, we send them to the emergency room or the intensive care unit. That's really something you have to be careful of. The major problem, again, is rebound. And people who rebound off of ergots are very, very difficult to treat. And for some reason, I say to my patients, you're habituated. I had a patient who I took in transfer who was at another hospital who came in to that hospital because the patient's arm had turned blue. She'd been taking 3 Caffragate suppositories a day for several months. They thought she was going to lose her arm. We brought her into the hospital. She had ulcers, so we really couldn't treat her with steroids, and of course we didn't want to use any ergots. And we tied her over with some neuroleptics, and she went home. And about 6 months later, she called me up and she said, "Dr. Schulman, I'm doing pretty good, except I'm running out of my Cafergot." I said to her, "What do you mean, running out of your Cafergot? I didn't send you home with Cafergot." She said, "Well, I found an old prescription in the back of the drawer, and I just refilled it." These patients, these are the kinds, for some reason, the people who use the ergots, sometimes will actually bring the ergots into the hospital with them. You have to be real careful with these. We use a whole lot of DHE. DHE is very, very effective. There have been a bunch of double-blind studies. We studied it at Germantown ourselves. When you compare DHE and prochlorperazine versus placebo, 29% of the patients had complete relief, and the other patients had at least a three-quarter relief. The major side effects that we were getting was nausea and occasionally slight chest heaviness. We start with 0.5 milligrams of IV DHE while they're in the hospital. They get reevaluated in another half hour. If their headache isn't gone and they're having no side effects, they get another half. And the protocol basically involves giving IV DHE up to 1 milligram every 8 hours, preceded by Reglan. Now, DHE is different than Cafergot, because it's a venoconstrictor. It constricts on the venous side. So patients who may not have been able to tolerate ergots will often be able to tolerate DHE. It's more effective than meperidine, and we combine it with Reglan. One of the big side effects is nausea. Once our patients come through the headache center, we teach them how to self-inject intramuscularly. And this is a big advantage for everybody, because when they get their headaches, rather than having to go through the ER, there's a class that we have, it's called injection class, and they learn how to inject a prescribed amount of DHE. They can limit it to twice a week, and they get complete relief in about 15 minutes. We looked at DHE, we had over 300 patients. IV DHE was effective in eliminating chronic intractable headache patients in 89% of the patients within 2 to 3 days. In our group, 90% of the patients were out of the hospital within about 7 days headache-free. Now, this is not to say that these patients don't relapse, and I think a lot of the relapse has to do with them taking their analgesics again. Sometimes we will bring people into the hospital, and when we bring them into the hospital, we tell them that they can walk around in regular clothes, they're not going to be strapped to an IV with monitors, etc. What we want to do is get them in a different milieu. Basically, the nurses who work with the patients are very caring, they're very empathetic, they respond to their problems with their headaches, they'll put blinds on the windows, and it's a different kind of atmosphere. One of the big advantages is they know that there are other patients who have headaches, because they always sort of think they're alone. But these people form sort of a social group by the end of the week. We take them off their analgesics and ergots, we treat them with repetitive DHE, we give them educational and psychological support. We have a social worker. We have 2 psychologists and 2 psychiatrists who work along with us. A lot of these patients are very depressed, and rightly so. We're not sure what comes first. Many of the drugs that I use preventatively are antidepressants. Whether it's an overlap because these are both low serotonin problems, we're not really sure, but they definitely need some intervention. And then the use of prophylactic medications. We usually start that while they're in the hospital. Now, we also use a whole bunch of adjunctive medications. When patients get dystonic reactions from Reglan or Compazine, we will give them Benadryl. With diarrhea, we'll write for Lomotil. Narcotic addiction, and we have a fair number of those patients, we either use clonidine or methadone. Patients who come in taking 12 or 14 or 15 furanols a day, we put those patients on phenobarbital, 100 milligrams Q12. Benzodiazepine, we'll put them on low doses of lorazepam. And then we have sort of our backup system. Patients who don't respond or the DHE doesn't carry them for the 8 hours, we might supplement with Thorazine or Haldol or Navane. We use steroids as a further backup, and we might put patients on methylprednisolone for a 3 or 4 day course to quiet them down. We measure the blood pressure prior to the first dose and second dose, and then 10, 20, and 30 minutes after the first and second doses. If the blood pressure is more than 150 over 95, we hold it. major side effects. About half of our patients got side effects, but they were mainly nausea. A lot of patients will complain of tightness and burning in their legs and leg cramps, vomiting, increased blood pressure, and chest tightness. Now, a lot of the patients will complain of chest tightness if the chest tightness goes on for more than 2 or 3 minutes and sounds like it's cardiac. I'll hold the DHE and get a cardiology consult. Obviously, you don't want to use DHE in somebody who's got coronary artery disease or peripheral vascular disease. We ask our patients, the females, to sign a contract saying that they are actively using a method of birth control. I should also say a little bit about Imitrex. Imitrex is a direct-acting serotonin 5-HT1 agonist, and it's given as an injection. It's indicated for the acute treatment of migraine with or without aura. It's not indicated in patients who have basilar artery migraines.
Dr. Schulman's remarks continue on Side B. Side B, Audio Digest Psychiatry, Volume 24, Number 12, returns to Elliot A. Schulman on migraine.
Basilar artery migraines are people who present with dizziness, nausea, ataxia, a lot of nausea and vomiting. Patients may be confused. The reason for this is it is a potent vasoconstrictor. The efficacy of the auto-injector, what happens is when you write for one of these things, the patient gets a test dose kit, and they are showed how to load the injector. There's a booklet. Actually, what we do is we have our patients bring the first dose into the office, and we teach them how to use it. And we do it for a couple of reasons. Number one, we want to make sure that they can tolerate it. Number two, we want to measure their blood pressure. And the third reason, there's recently been reported a death in England on somebody who was taking Imitrex. So I think for a lot of different reasons, it's important that you have the patient cleared by somebody medically who feels comfortable that the patient can tolerate it. The efficacy is actually quite high. 2 hours afterwards, about 83% of these patients were doing very well. I think one of the big drawbacks to the drug is its cost. Each treatment, not each unit, a unit is 2 vials. Each treatment is anywhere from $25 to $35. It's good for in-office administration, and again, we do it for everybody, but it's a good educational opportunity. We give our patients the Imitrex when they are not having a headache. So we don't really know how effective it's going to be. Our basic reason, again, I'm saying, is to measure their blood pressure and make sure they're not having untoward effects. Sumatriptan in the PDR, they tell you that it can be taken every day. We think that there are people who can rebound from sumatriptan. They say that the safety profile is not affected by the frequency of use. We try to ask our patients to take no more than 2 doses of sumatriptan twice a week. The big side effects is a problem at the injection site and flushing. Patients have gotten nauseous, dizzy, and then once in a while you get a patient who complains of a heaviness in their chest, but that's similar to DHE, and we're usually able to sort it out. It obviously has the same contraindications as DHE, ischemic heart disease, angina, hypertension, or ergotamines. The other contraindication which just came out was it should not be used in patients who are on MAO inhibitors. Now, we have patients who don't respond to this stuff. So, as I said, we might put them on a Medrol dose pack or a short course of steroids as an outpatient. Neuroleptics, my patient who used the Keforgat, when she gets her bad headache, she uses Navain or Haldol or Thorazine or Compazine. We don't use a whole lot of narcotics, and narcotics are reserved for those patients who are not doing well, and actually they end up going to the emergency room. The other thing that we do use as an injectable is Toradol. Toradol, these people, they know how to inject themselves already, and we usually give them 60 milligrams of Toradol, and that really is very, very effective. When you're starting somebody out on a preventative, what you want to do is start low and increase slowly. So I will start, if I'm picking Pamelar, I'm picking that out of the air. I will start with 10 milligrams of Pamelar. There are some people, after 2 weeks of 10 milligrams of Pamelar, They're basically headache-free. We move up and titrate very slowly. You have to make sure that your patient is not analgesically rebounding, because if he's rebounding, any preventative that you pick for the patient is not going to be effective. So patients will come in and say, well, I've been on Pamelar, I've been on Zofran, I've been on Paxil, I've been on Norpirmin, well, all those times, have you been taking 20 Fioricet a day? Yeah, well, that was the only way I could get relief. What you want to do in a patient like that is get them off their analgesics and go back to the other drugs that didn't cause side effects, because now they may be useful. We oftentimes will do drug screens on our patients. Again, the pregnancy issue and when to stop drugs. Patients will come in to me and say, I'm really feeling good on this Prozac, and I don't have any headaches. When do I need to stop that? And that becomes a decision between the patient and I. If the patient is feeling good, if they're satisfied with their general feeling about themselves, if they can afford it, if they're not having any side effects, then I urge them to continue it. If they want to come off, we titrate it very slowly and tell them that, again, this is a treatment, it's not a cure. If your headaches come back, I would not be surprised. Most of our patients actually elect to stay on their preventative once they're well controlled. I usually start with the antidepressants. I like Pamelar. It's not as sedating as Cinequan or Elavil. It's not as constipating. It doesn't make people as tired. We start real low, as I told you, and move up. We do use Elavil. I use it a lot less frequently than I did because I'm using a lot of the SSRIs now. Amitriptyline was initially used for trigeminal neuralgia, and somebody had the bright idea that if it was working in trigeminal neuralgia, why not try it in headache? I'm not sure if you're aware of this, but Elavil and Pamelar, all these drugs are not really indicated in the PDR for the treatment of headache. We use Prozac. I use a lot of Prozac. I like to start with 10 milligrams of Prozac in the morning, warning my patients about the possible side effects. Everybody's heard the bad publicity about Prozac. I have a couple Xeroxed articles in my drawer that talk about that this has been overstated, but I let the patient make their own decision. If they don't want to be on Prozac, then we'll maneuver into something else. I particularly like the Prozac because it's not going to cause weight gain in most cases. It can. Patients usually have very little side effects with it. I think the biggest side effect that I've seen is some jitteriness. Once in a while, some transient nausea. We've used this and had very good success with it. I also use Paxil, and I start out with 10. I also use Zoloft, which I have not found as effective, and I also use Effexor. Effexor is sort of my fourth-line drug in the non-tricyclics, and I use this in people who I think have refractory depressions, who are not aware that they have refractory depressions and will not go to see a psychiatrist. We use a whole lot of the calcium channel blockers, and they're very effective in people who have complicated migraines. Doctor, I get this funny feeling in my side of my vision, my hand goes numb. Next thing I know, in about 15 minutes, I feel my vision is gone, but I got terrible nausea and vomiting, and I'm in bed for a day. That's the kind of drug for patients who would benefit from a calcium channel blocker. I basically use Kaolin and Procardia. I like Kaolin except for its constipation. I don't like Procardia because patients do get some postural hypotension. Patients will also on Kaolin, and we go pretty high up on the Kaolin. We'll go up to 80 milligrams 5 or 6 times a day and keep an eye on their blood pressure and do an EKG, depending upon how the patient is in terms of their other medical problems. What I don't like about Procardia is it does cause some postural hypotension. I don't use a whole lot of beta blockers. The kind of patients that I'm seeing are already depressed. So to put patients on a beta blocker oftentimes makes things worse, not better. If I'm going to use a beta blocker, I'll start out with Inderal LA60. I like that because it's a once-a-day dose. If the patient can't tolerate it because they're getting more depressed, then I'll switch over to Corgard or Tenormin and see how they do with that. The major side effects, obviously, is somebody who's got congestive heart failure or asthma. I use Sansert. These are drugs that I use with a lot more reticence than I would the first drugs. The major problem with Sansert, it's very effective, but it can cause retroperitoneal fibrosis. What I do is I put my patients on the drug for 5 months, take them off at a month. They usually do phenomenal on the drug. Idiopathic, the retroperitoneal fibrosis, I only see them once a month. I'll only give them prescription for once a month, and they've got to come back to me. We also have patients who are on Nardil or Marplan. We do actually very well in patients who are refractory depression, who have not responded to anything else. What we do is build it up slowly. When my patient comes in, about 2 or 3 visits before I'm possibly thinking about putting them on it, I'll say, look, I'm going to give you an MAO diet. This is what you need to know about the MAO diet. You can't cheat, because if you cheat, your blood pressure is going to go up, and this is what can happen to you. I ask them to stay on the MAO diet for 2 weeks. If they can stay on it and they can handle it, then we wash them out from their antidepressant and slowly put them on Nardil, and if we can, as an inpatient. The dietitian comes to see them. We go over all the drugs that they can and cannot use, the antihistamines that they have to avoid, etc. We found this real effective. Dilantin is touted by some of the people being helpful. I really haven't seen it so. We are using a whole lot of Depakote. Depakote is very effective for patients who have chronic refractory headache. Patients seem to tolerate the Depakote without much problem. Again, it's a drug that I use not so much when it's at a therapeutic level, but when it's doing what it needs to do. And I've got patients who are on 250 milligrams of Depakote 3 times a day who are headache-free. I'm sure that their level is subtherapeutic. The therapeutic level, as you know, is about 50 to 100 micrograms per ml, and you can go very high with this. I think the big side effect that the people have expressed some concern about is weight gain, and I've had a number of my patients gain weight on this. We also obviously monitor for hepatic toxicity. Periactin is a drug which is used mainly in children. I don't use it a whole lot, but it's very effective for headaches in children. And methergine is also very effective. Methergine is sort of a cousin to ergot. This is another drug that can only be taken for 5 months at a time, and then the patient has to come off of it. I had a patient who was on methergine who was doing wonderfully on methergine, and her 5-month anniversary came up, and I said to her, you're going to have to come off your methergine. She said, well, this is the first drug that's worked for me. I said, well, I'm not going to renew your methergine. She said, you know what? I'm going to come in, I'm going to write a disclaimer. I'm not going to sue you. I'm not going to have you take any responsibility. I'll come into your office, and I'm willing to take the chance. I said to her, well, why don't you come in and we'll talk about it. And she had been on everything, and she really was not doing well. I was examining her, and I noticed that her foot had turned blue. And I said to her, what's going on with your foot? She says, oh, my foot turned blue about a week ago. Sure enough, she had no pulses. And I sent her to one of the vascular doctors who said that she, in fact, had vascular compromise. So I tell you this because you really have to be very, very careful when using these medicines. Histamine desensitization is supposedly effective for cluster, which I didn't talk about. It doesn't work. Papaverine doesn't work. Intravenous reserpine is going to make your patients very depressed. Catapress is sometimes helpful. And sometimes when you can't take a patient off their analgesics, you can give them a catapress patch. And you can slowly decrease the amount of the catapress over a 6 or a 9-day period, and these patients seem to be able to tolerate it. Again, I want to stress analgesic overuse. More than 100 simple analgesics per month. I had a patient who came in who was taking 40 Percodan per day. Taking 40 Percodan per day. We brought the lady into the hospital. We detoxified her. She had not been headache-free in for 5 years, and within about 3 days, she was well on very low doses of a preventative. Again, when you're overusing the analgesics, the symptomatic medicines are not going to work. You're going to need more of them. When you stop the symptomatic medicines, your headache is going to get much, much worse. That's why we like to bring people into the hospital to give them the DHE to make sure that they can tolerate the DHE, and it makes the withdrawal process that much easier. They get better after they stop the medications, and the preventatives are going to be ineffective. I just want to talk a little bit about diet. Again, just to reinforce what I said, if somebody says to me that every time they eat peanuts, they get their headache, I tell them, oh, fine, then eliminate the peanuts. But doctor, My other doctor said I shouldn't drink beer and I shouldn't eat pizza and I've given up on hoagies. Unless you find that one particular food is persistently causing your headaches, don't cut them out of your diet. We use a lot of physical therapy, stretching, relaxation, psychological therapy, which I'm not going to really get into, but we do have a lot of our patients who get into counseling, stress management. Patients who are good candidates get into biofeedback and relaxation. And a lot of times you'll need to get the family involved, because when mom can't go out because of her headaches and she can't take care of the kids and the husband's got to stay home, and on Saturday nights nobody can leave the house because mom's not feeling good, it really has an impact on the whole family. So oftentimes we will get the family involved. I'm hopeful by using some of these tricks that I've told you that you can take a patient who feels alienated and outside of it and make their day a little bit brighter.
Now, teenage headache, muscle contraction headaches that commonly accompany stress in adolescence, by A. David Bothner, Chief of Pediatric Neurology at the Cleveland Clinic.
What I'm here to talk about is the patient who presents to your office, looks at you smilingly, and says, I have this terrible headache that's killing me. And I have this headache every day. And I've had this headache every day for the last 3 months, and I've missed 21 days of school. And this is what they call tension headaches. And if we draw the diagram, the patient comes to you with headaches that never seemingly get better, never seemingly get worse, and go on and are present by the time they see me for 60 to 90 days. Again, tension type headache is what I call chronic, because it's lasted longer than 60 to 90 days, non-progressive, meaning it's not getting worse. It's been known by a lot of names: tension, muscle contraction, stress, or ordinary headache. This is 3 times more common than migraine in the adolescent population. And again, the intensity of the pain, especially in children who have mixed headaches, is always described as being less severe than migraine. There are 2 kinds of tension headache. This one might not get to your office. Episodic. There may have been 10 episodes. They are certainly not every day. They last minutes to days. They are described as tight, of moderate intensity, in the front or around the head, and really are not severe and may be relieved by mild analgesics. This, however, is a different story. Daily headaches, and this might be at least 15 days per month, or in the adolescent every day. The child may have been taking excessive amounts of aspirin, Tylenol, and ibuprofen. Now, if we look at this chronic headache, okay, and the episodic headache, these patients describe a tight, squeezing, aching feeling on a daily basis, and they somehow do not get relief by Tylenol or aspirin or ibuprofen. The previous idea was that this was due to muscle contraction, and there were even studies that showed EMG abnormalities. Current thinking is more honest. It says we don't know what causes these headaches, but there is a relationship between body and mind. Now, the onset of these muscle contraction headaches is frequently in adolescence. I don't make this diagnosis readily in children under 12 or 14. In those children, I'm more likely to be fooled, and in those children, I more likely study them. And again, stressful situations may play a role. Of interest is that if we look at these chronic daily headaches in teenagers, anywhere from 5 to 7 times more common in girls and young women than in boys. In 60 to 70% of migraine headaches, there is a family history. That is because migraine is a genetic disease. This is what we call environmental genetics. The father or mother might have daily headaches, but this is a learned behavior, not a genetic behavior. Again, muscle contraction is not associated with nausea or vomiting. These patients may have some mild symptomatology, such as chronic fatigue, some dizziness, and that's it. But they don't get a lot of nausea or vomiting that come along with them or are precipitated by them. There is no aura in muscle contraction headaches. There is an aura in classic migraine. The frequency of attacks is interesting. The usual child gets anywhere around 2 to 3 attacks per month of migraine. The usual adolescent has these headaches either multiple times per week or more likely every day. The severity of the pain is very, very interesting. If you ask a person with chronic daily headaches, she says the pain is terrible. It's a 10 out of 10 and I have it now. And you look at them and they're in no distress. I get a better answer when I see the mixed headache patient. They say the severe one is the migraine, the tension headache is less severe. Adults will usually describe it as band-like, whereas children will describe it as bifrontal. In migraine, nausea, vomiting, bothered by light. In these patients, they rub their neck, they rub their head, but they don't get a lot of nausea and vomiting. And again, the duration of the attack is either continuous or persistent as opposed to 6 hours or 8 hours in migraine. And it is not unusual for the patient to have symptoms that are disproportionate to the headache. In other words, our brain tumor patients, our leukemics, are in school. Why should a patient who can walk and talk and come into my office be out of school for 2 years because she's got a headache and nothing can be found? So this is a big tip-off. When these patients come to talk to me, especially if they have what we call the valedictorian syndrome or somatoform disorder, they have a lot of complaints. Some of them have recurrent abdominal pain, some limb pain, some chronic fatigue, and some fibromyalgia. They say, "Doc, you gotta believe me, this headache is terrible. They're dramatic, it's ruining my life." If you ask them, is there anything in your life that's stressful? No, it's like they're dead. There are no stresses in their life. This is the worst pain. Only you can help. Nothing has been helpful so far. How do we at the Cleveland Clinic, who have an interest in this disorder, evaluate these patients who are truly severely handicapped? We evaluate them by a thorough neurologic evaluation, but also have them see our child psychologist. What I want somebody is to look at life stresses. So there's an interview with the parent alone, the child alone, and then together. The adolescent, 14 to 18, is given the MMPI-A, and the parents are given the PIC. The psychologist asked about moves, new schools, deaths in the family, change in the routine, and big social stressors. History of other somatic complaints, how the child has been treated before, and how this upsets their daily life. In addition, the psychologist and I both look at what the child acts like, what pain behaviors, and we watch the interaction, the hostility sometimes, between parent and child. Again, the MMPI is 500 questions. It is very, very well normed for adolescents. It gives you a global assessment of personality. And our patients with the somatoform have problems with the validity scale, with hypochondriasis, with depression, sometimes with hysteria, and sometimes with some of the others. But these are the most common. The personality inventory for children is filled out by the parents. It's a 300-item questionnaire that's well normed as well. And again, there are different scales, and the big scale here is denial. The parents think everything is just fine and there are no problems. Now, when we get done, the psychologist and I will look at the situation together. If there are no significant elevations on any of the stress-related inventories, maybe we should go back and look at further things medical. If there are highly defensive people, and these people can be highly defensive in that they don't want to admit there could be a stress-related etiology for their physical problem. They insist, even after 3 MRI scans, that there's got to be a physical problem and I'm missing it. Again, if it's a somatic profile, we're talking about therapy, and if other psychological problems like depression are present, we go further. Now, what about treatment? People have been trying to treat headaches for hundreds of years, whether they're using Dr. Carter's little liver pills or some other type of medication. Now, obviously, the treatment plan is going to depend upon the psychopathology, the age, the family structure, the resources. There are some areas of the state where there are no resources, and it's very, very difficult to get mental health or good biofeedback. Judicious use of medication, not, repeat, not narcotic analgesics, but tricyclic antidepressants. There are many behavioral forms, and there are many physical forms of treatment that can be helpful. We have to take a look at what the pain is doing to the child. If the child wants to be out of school, wants to get constant attention from the parent, is afraid of going out into the world, then I think unless you take those secondary gains away, treatment is going to be very difficult. How do we approach the problem? We never say to them the pain is in your head or that it's psychological. This is real pain brought about by stressful situations. We emphasize that we have done a complete evaluation and you ain't going to die from your headache. We have them keep a diary so that they're in control of the symptoms. We see them on several visits. We try to remove any stressful situations when that's possible. We minimize narcotic analgesics, and we use tricyclic antidepressants. Now, the one that I like best is amitriptyline. I use it all at night in an average 14 or 15-year-old. If they're very sensitive to medicine, I'll start at 10 milligrams. If they're not, I'll start at 25. Every week I'll increase it until I get in a 15-year-old to maybe 50 or 75 milligrams. And then I'll check levels to make sure the patient is compliant.
Thank you, gentlemen. Audio Digest Psychiatry is produced twice each month by the Audio Digest Foundation, a nonprofit subsidiary of the California Medical Association. This tape is copyright 1995.